Dr. Hetu, postgraduate student. It will be on carcinoma tongue involving the floor of the mouth.
Resident of MP, Madhya Pradesh, present with a complaint of ulcerative lesion in left side of tongue since last 1 year, sir, which was rapidly increasing.
Ulcer proliferative है या फिर ulcerative है?
Sir, this is ulcerative growth, sir.
Actually, it's also proliferative.
Complaining of ulcerative proliferative growth in left side of tongue for last 1 year, sir, which was rapidly increasing in size since last 6 months, sir. And associated with restricted tongue mobility since last 2 months, sir. And no history of bleeding from lesion, and no history of loosening of teeth, and no history of loss of sensation over chin, or no history of restricted mouth opening, sir. And no history suggests of any distant metastasis, sir.
There is loss of sensation or there is not?
No loss of sensation.
Like how is it?
Sir, no loss.
Which loss of sensation you are asking for? Since you mentioned, that's why he's asking.
Sir, yeah. Actually, tongue, the floor of mouth, it contains hypoglossal and lingual nerve, and
Loss of sensation where? When you say go back to the slide,
cheek, sir.
you mentioned that.
Chin, sir.
Written right.
Chin, sir.
You have written right, but you are
Yes,
speaking.
sir. Chin, sir. The patient was a chronic tobacco chewer and smoker, alcoholic for last 20 years, sir. And he was telling he took some treatment in Gwalior 10 months back, and they managed it as a oral ulcer, sir. Some JT solution and antibiotic they have given, sir. And he is also telling they have taken some biopsy, it's negative for carcinoma, sir. That's why they treated like that, sir. And bowel and bladder habits were normal, and no history of head and neck related malignancies in first degree related. On general physical examination, patient was hydration and nutrition status was adequate on account of BMI 22.5 and performance status 90 by Karnofsky's performance scale, and patient is vitally stable and no icterus, sinuses, clubbing, pedal and no general indifference. On head and neck examination, facial symmetry maintained, around 5 into 2 cm ulcer proliferative growth present on left side of tongue with irregular margins and everted edges, and slough on the floor of the ulcer, and growth is fixed to floor of mouth with induration extending beyond the margins of lesion, sir. And posterior limit of the induration could not be appreciated on palpation, sir. And the ulcer is non-tender and did not bleed on touch, and tongue mobility restricted in all directions, sir. And oral hygiene is poor, and teeth are nicotine stained, and malmoplegic patches present over the buccal mucosa.
Here he is written correctly, it was also proliferative growth.
You later on, why is it? There's a world of difference between ulcerative and ulceroproliferative in the matter of outcomes.
Yes, sir.
Therefore, it is very important.
You can tell him now.
Okay, fine.
They'll all learn the outcome.
See, ulceroproliferative means that it has very good blood supply. It is getting nutrition. That is why it is proliferating.
Yes, sir.
Understood? It is very well oxygenated. Everything of that.
Of all the oral cancers that are poorly oxygenated, this would be a better one. That's what he's saying. Because it is proliferating, so it has good oxygen supply.
I don't know how amenable this is to surgery now.
We'll discuss that.
It is, but if we give radiation, or for that matter chemotherapy also, since it is so well perfused, all this therapy, radiotherapy, it will be very well oxygenated. Therefore, more number of free radicals will form inside the better cell kill. Chemotherapy you give, more of it will.
So being oxygenated will do better.
Understood? So
That's why it makes a difference.
Huge difference.
And whenever you describe the growth, see with this surface I cannot, it's whether in the anterior 2/3, it's in the posterior 1/3 where it is starting from,
Yes, sir.
and whether it is crossing the midline or not, because it makes a difference in your surgical
I
management.
think you, again, see the point is, it is just in your description. You've written it. Posterior limit and duration could not be appreciated on palpation. So it is basically, essentially from the pharyngeal tongue. Where is the pharyngeal tongue? Which is the oral tongue.
So, pharyngeal tongue is behind the circumvallate fibrosis.
So where is it? Because the behavior is
So,
different.
actually, it started
No,
from
behavior is different. He is asking for a reason. Where did it start?
Sir, it started from oral tongue, sir, and it extended
So
posteriorly.
that's the point. So it's an important question.
Yes, sir.
And you now answered it. If you mentioned it, how would it help? You are basically, you started in Connaught Place and you reached Green Park versus now you're all over the place. You started in Green Park, reached Connaught Place. You know, oral tongue is a totally different behavior, like inner rectum. Now they changed it from anal canal or rectum to inner rectum. That is which way it goes.
One more thing. What will be the history? What will be the presenting complaint if it would have started from the base of tongue?
So,
It is very easy
swallowing.
this one question will tell you.
Answer it.
Ah,
Difficulty in swallowing.
Okay. Let's
good. Continue.
So, this is the lesion, sir. So,
all of you have a look at it.
sir, left side.
Yeah, it's not amenable to surgery, that's why we discussed.
So, the lesion started left side, sir, and it extended posteriorly, posterior part of tongue, and the induration could not be appreciated, sir, the posterior limit of induration. This is the lesion, sir, and here also lesion, but we are not able to take the picture. On palpation, we can feel the lesion on left side also. And tongue also slightly turned to left side because of this lesion on left side.
Why the tongue
नहीं,
shifted
नहीं,
to the
नहीं,
left
deviation
side?
क्यों
Yeah,
हो रही है?
left. You're rushing. Why does wheelbarrow phenomenon happen? This is wheelbarrow phenomenon.
Yes, sir.
Why does it happen?
Sir, hypoglossal involvement.
Leading to?
So leading to ipsilateral genioglossus palsy.
So it's because of the crisscrossing fibers of the genioglossus and therefore fan shaped. So on the affected side.
Okay, listen. Wheelbarrow phenomenon. Amit the restless you should do. But why? And you will get a wrong answer from the mail coming.
So anterior two-third involves are partly involved, sir, not till the tip of tongue.
And don't buy that argument that muscle pushes. Muscle can only pull.
Can you go back to the previous slide? Is this part involved or not?
No, sir, this part is not involved,
This
sir.
part is
Only the lateral part of
Only the-
tongue, but tip is not involved, sir. The only lateral part of anterior to
Is there any induration there
Yes,
on
sir.
palpation?
Yes, sir, induration.
So that is involved or not?
Yes, sir.
Involved.
No, sir, in this part, no induration, sir, but lateral from middle.
So how much is the induration beyond the lesion? Difficult to palpate, I can understand. And you've done well to take the picture because the mouth opening is still adequate.
Adequate, sir.
And what do you think of the extent? Can you tell them, because they'll be interested, no?
Sir, the induration extending around 1 centimeter beyond the margin of ulcer, sir. But the posterior part of induration on palpation could not be appreciated.
Anything on?
Could you feel the induration beyond the lingual surface?
Sir, posteriorly,
Beyond the midline.
it crosses midline, sir. But anteriorly, it's beyond the
Palate,
limit.
all right. दिख रहा है
Could
मुझे
be,
वो.
could be.
Where is the uvula? Take your pen there. Tapas pen है ना? Particular.
The epiglottic folds are involved, sir.
They involve, no? Clinically.
No, sir.
Sir,
Clinically,
it-
more.
What is मतलब?
Soft palate.
Clinically, the soft palate would look like involved.
Involved.
Yes.
No, sir, actually gap is there, sir, but taking photo.
I'm only asking, is it involved or not?
No, sir, no.
Clinically,
Clinically not involved, sir.
वो दिख तो रहा है.
Anterior pillar was involved, sir.
Anterior pillar of.
Tongue.
Palatine tonsil.
Palatine.
So that is involved, so palate is involved.
Yes, sir, palate is involved. But
Please come, Dr. Amit.
Sir, but
Yes, please carry on. Sorry, there was interruption. अब ये बिस्किट एक बार रख दो, फिर बैठ के पढ़ लो. हाँ?
sir, here the lesion is going toward the anterior pillar of palatine tonsil, sir.
Involvement.
Yes, sir.
दिख रहा है.
Yes, sir, okay. Sir, on lymph node examination, around 1 into 1 centimeter fixed non-tender lymph nodes present on bilateral level 1B region, sir, submandibular region, sir. And 2 lymph nodes on right side, around 3 into 2 centimeter and 1 into 1 centimeter, hard fixed non-tender lymph nodes, sir. On left side also, lymph node on level 2, 1 into 1 centimeter, hard fixed non-tender lymph nodes, sir. Bilateral level 1B and 2 lymph nodes are involved. Sir, histopathology of corneal biopsy suggests of fully differentiated squamous cell carcinoma, sir. And
Edge biopsy or core biopsy?
Sir, edge biopsy, sir.
You said core
Sir,
biopsy.
no, sir, edge biopsy from.
Relax. You want tea?
No, sir. Sir, and CECT head and neck done outside, sir. It's the issue of heterogeneously enhancing lesion in left anterior to the.
CCT would like Amit to interpret for you.
Yes, sir.
Yesterday we were talking about, Vikas had shown you with a important purpose and one last time, so you should see it today. We got a radiologist to address that issue, so you finish with the findings.
Sir, heterogeneously enhancing lesion in left anterior two-third of tongue, also involving root of tongue and showing extension into posterior one-third, sir.
Dated कब का है CT?
Sir, last month, sir, in February.
CT से अभी 5-10 days पहले।
5 days, sir.
ऐसा ना हो कि बहुत
No, sir.
नहीं,
Recent is recent, sir. And it measures 3.8 into 3.2 into 2.7 lesion is indenting the lingual septum but not crossing the midline, infiltrating into the extrinsic and intrinsic muscles, laterally averting the mandibular cortex without cortical erosion, sir. And posteriorly obliterating the left anterior palatoglossal fold and infiltrating into left palatine tonsil.
You will show all these areas of it. Yes. Because it's my hair, film में. You have the CT
Yes,
here.
sir.
Okay. It's bad actually.
Sir, also PP.
हाँ
Sir, also made one.
सर आई
Excellent. That will help.
मैं SR in the department of radiology. With your permission, sir, can I just sit?
And one more introduction to him. He was probably one of the best students I had the pleasure of teaching. He was just sitting, others are also here. And he had to become a surgeon actually. But the tragedy as it would happen, he topped the list. So he was forced to become a radiologist. Suddenly you, but then in radiology he made a difference by being exceedingly good person. For all our guided work, he comes. We are going to have more of it tomorrow. We'll come tomorrow. Tomorrow we have practicals. Please come.
So, with your permission, I would like to sit and discuss with you.
Please.
So we have limited axial contrasting CT scan of the neck from the base of the skull to the thoracic inlet. So we see a heterogeneously enhancing mass lesion involving the left anterior part.
If you allow.
A heterogeneously enhancing mass lesion involving the left anterior two-thirds as well as the posterior one-third of the tongue. So on scans below, we can see the lesion is extending up to the mandibular cortex anteriorly. However, there is no obvious bony erosion. Slightly lower down, we see that the lesion is involved the lingual septum as well as the left-sided sublingual space.
Lingual septum.
It's not seen, sir.
So how do we know?
This is the lingual septum, sir. This is the lingual septum, and just lateral to the lingual septum we have the sublingual space which houses the Watten's duct, the lingual neurovascular bundle. So on the left side the sublingual space is involved. See this, this is the genioglossus, this one. This is the lingual muscle, and we can see that this entire mass is involving the tongue. On these images we can see that there are multiple lymph nodes which are level 2, and here we can see that there is a large heterogeneously enhancing lymph node, and this is the mass. So the mass as well as the lymph node are together encasing the carotid space, and it is approximately more than 270 degrees of encasement. Again we see a left level 1B lymph node, and there is a right level 1B lymph node as well. We can also see that the lesion is extending up to the tonsillar space, left-sided tonsillar space. This is the slightly lower down section. The lesion is not involving the epiglottis, so it is above it. I've included some corneal scans as well. So CECT is not really the modality of choice to see which extrinsic muscle of tongue is involved.
That you need MRI.
For that we would like to have an MRI. But here we can see that there is a large lesion, and it appears to involve the mylohyoid. However, the anterior belly of digastrics are spared. So there is some amount of maxillary sinusitis, which is an incidental finding on the right side. This section I've included to see if there is any extension to the mandibular foramen, if there is any perineural spread. So since this is on the left, this is on the right, so we can see that the left mandibular foramen is slightly widened as compared to the right side. I had only this section, so I would like to see the section before and the section in front and behind it. But we can say that the mandibular foramen is widened, so I will suspect a perineural spread of tumor. Coming back to the axial sections, the other new perineural spread that we see is the involvement of the inferior alveolar nerve. So that there is no erosion of the mandibular cortex. So by and large, there is no inferior alveolar nerve involvement. So to conclude, there is a large mass lesion involving the left-sided tongue, anterior 2/3 and posterior 1/3, medially abutting the lingual septum and involving the left-sided sublingual space, posteriorly extending into the left tonsillar space, and with suspicion of widened mandibular foramen. So I would like to suspect a perineural spread, along with N2B metastatic cervical lymphadenopathy. And the metastatic workup, we didn't have the chest film, so I didn't. Thank you.
Right, thank you.
Very informative.
That's why it is assessed.
It is informative to me at least, and it will be informative to you. So he told very, very crisp points. Each and every point of his has a brilliant illustration under it. He said that the involvement of the lymph node, there was a 270-degree encasement. Why is that important?
Next T4A.
क्या होता है ये 270 डिग्री 90 डिग्री लेस देन 90 डिग्री क्यों लिखा होता है रिपोर्ट्स में?
Please explain what do you mean by 270 degree?
Sir, 270 degree would say that it is very hard to excise the lesion without having negative margins.
It is a lot of it is common sense. Don't get perturbed. When you're looking at the borderline dissectability of periambulary cancer, we discussed it 180 degree, 270 degree. What are you looking at?
Resectability.
And you will know whether you can resect it, it's borderline or it's not resectable. The same thing applies here. Now, how does it make a difference if you know the node is not resectable? You're looking at extracapsular spread as one thing, which is a predictor of bad outcome. So, but it helps to see. I mean, the terms have to come, as Vikas said, for people to think about it. Because many a times things are rare because you don't think about them. And if you hear it many a times, like you heard intratemporal fossa, they're all using that edema up to the zygoma in all presentations for that purpose. So that makes sense. Once the thought process starts, the brain works that way. Anything
आपको
else?
नहीं समझ में आता तो आपको पूछना चाहिए था ना भाई. ट्रेनिंग आपके लिए हो रहा है सारा कुछ.
पूछना चाहिए.
Another beautiful term, he said that I would prefer an MRI investigation. Anything you would like to do on this to make it as equivalent as an MRI? He had a limitation of a ITF or probably the perineural invasion involvement. So, do you think what you can add to it in the CECT to make it as equivalent as an MRI?
How do you make it analytical? They won't know.
So there is a bone algorithm. So all patients of head neck, you should, when advise, because when you advise it from the outside in the private hospitals, by default, if you write them with the bone algorithm, they will write it and it will make it as, so muscle involvement won't be there, but then again, if you do it for all patients for your head neck, the CECT head neck, when you advise for the buccal mucosa or other, just write a word bone algorithm. It doesn't cost the patient anything, but the radiologist on the back of the mind knows that you will get a clear picture of ITF, you will get an ITF clear picture of perineal invasion.
Bone algorithm in Tata is already, that's what they look at. You attend their activities. there is somebody who gets up to explain it. Can you tell us?
Sir, like to substantiate that. So whenever we look at a CT scan, there are a lot of windows based on the HU values. So we have a soft tissue window which we are looking at right now. And then there is a bone window in which everything is dark, but the bones are very nicely seen. So you can see the cortex, the marrow, as well as all the foramens. Apart from that, we have a lung window. So we have a window for everything, and as a routine, at least in our center, we see all windows. But it might be a thing that we don't give films for everything.
So we mentioned private, which will get out of expunge it, as they say.
So
in the parliament, we'll expunge it. You did private doesn't mean we certainly the best possible radiology department that you're gonna ask for. But when you mentioned about the
But you do it with the algorithm when you do it.
So we do it, and it is a
The reporting is
reconstruction
done by
tool.
that.
can you,
So we
can
don't-
you
we just
elaborate
need to
on that, Amit, the bone algorithm term used?
So bone
In
algorithm,
head and neck they use it very
we call it windows, windowing.
That's why I'm saying.
Yeah.
Just go back.
Okay.
Read it
Next time
because
we'll
it
discuss
requires
that.
a oral.
Why would we discuss it? Bone algorithm, next time you come prepared.
Yes.
Years. Now, one thing you mentioned about because to us, the involvement of the alveolar nerve is as good as the involvement of mandible, and then mandible cannot be preserved. You said there is a widening of the
Foramen.
right?
So I said there is a widening
It's
of the
one
mandibular
feature,
foramen.
mandibular foramen. Any other feature that you look for?
Sir,
Will that be
for-
better in MRI?
So for perineural spread, on CT the only sign is widening of the foramen as compared to the contralateral
That's
side.
only-
And on MRI we can see enhancement of the nerve. So I would like to do a
MRI
MRI
for the
contrast
enhanced
MR
nerve.
study extending up to the base of skull and a little bit of the brain, so we can see the enhancement if there is any.
Good, clear?
Yes.
People asked for it, so I thought I'll add it. Move. Can we move, Amit?
Plan.
We've done this? Yes, that's the case.
To
You go to the
conclude,
plan,
it is
you will open it.
T4B N2B MX. For me.
T4B it was, and 2B. What's the end stage, the head and neck?
So NX when no lymph node can be assessed accurate,
No,
when lymph
cannot
nodes cannot be assessed
assessed
accurately. Yes, sir. N0 when there are no lymph nodes palpable. N1 when there is ipsilateral single mobile lymph node of less than 3 centimeters. N2 is further divided into A, B, C. N2A when there is the lymph node size is less than 3 to 6 centimeters, single ipsilateral mobile. And N2B is when there are multiple ipsilateral lymph nodes which are less than 6 centimeters. N2C is when there are either bilateral or contralateral lymph nodes less than 6 centimeters. N3A is when there is lymph node more than 6 centimeters but there is no extracapsular extension. N3C is when there is extracapsular extension along with lymph node size being more than 6 centimeters.
Correct. Why 6 centimeters such a sacrosanct figure?
So because no lymph node can grow to alone
So
can
it is
grow to
expected
size.
that it's a
Conglomeration of multiple lymph nodes.
And usually the bad side. Is it resectable? It's not.
It's not, sir.
N3 is not a resectable. Even N2
C.
C would be difficult to resect. So therefore, this concept of how much degree. Are you all right? Now that's the case. Open it.
Next plan, sir.
प्लान तो तुम खोलोगे तो उसको तब बोलेंगे ना प्लान एक्चुअली फाइंडिंग इज ऑलराइट अमित
Yes.
यू सेड डेलीवर इसको abutting left malar to practice complications of the space plan.
So
Is it surgically resectable?
No, sir.
Okay, so no surgery. That's what.
CT for this also.
No, only, no,
The other one.
so we'll start first. Why do you think it is not resectable?
It's encasing around the carotid and posterior one-third of tongue involving
What is the stage?
stage T4B, sir.
खत्म हो गया.
Yes, sir.
उसके बाद let him ask you why T4B is not resectable. T4B means non-resectable.
Yes, sir, not a-
Don't start explaining it again like a parrot, same thing. Why is it T4B?
Sir, it's encasing around carotid, sir.
बस वही सवाल है उसी का वही जवाब अलग आ गया ना. तो what more intelligent answer would be T4B and it's not resectable. Isn't it? Now, why is it T4B? You answer only one thing, carotid encasement. Anything else? What is the difference between resectable and operable? You very loosely used terms.
Patient is operable or inoperable, otherwise tumor is resectable or unresectable.
Loosely used. Anybody is operable if he's fit for anesthesia. You take a biopsy also is operated. But resectable means when you can get a
Clear margin, R0 resection.
Can you get R0 margin?
Before sending to any other department, what you'd like to do for this patient, which you think you have missed of it, or for all head neck malignancies, it is an important assessment to be done.
Any office procedure that you will mention? Anybody?
So indirect laryngoscopy to rule out field cancerization in the patient.
Will have been done? It has been mentioned, at least, that I would desire to do.
Posterior extent you couldn't feel in the clinical examination. That's why it's important to go down and see it. Anything more you would like to do?
So, for chemotherapy workup, could you
AD also देगा, आप भी देंगे. Anything more that can be done?
We will go to chemotherapy, but before that also, what the patient came with,
Junaid, anything more that he can do?
Oral.
After 5 years.
oral ulcers,
tongue cancer and
swelling or probably, so there is a thing known as speech and swelling assessment to be done. Each and every patient should get it done. They are simple tests, just like water swelling or something like that. They need to be assessed before you. So there is a morphological loss and then there is a functional loss. So you need to see whether that hypoglossous is involved clinically with speech and swelling. You need to see what's the functional impairment the patient is having right now. So that needs to be done.
SNS, speech and swallowing.
And who will read it, because it involves at least 5 scores. So
Who will read?
there is an endoscopic, there is a visual, there is a functional, there is an FS score. I've just given you 4 broad headings because it requires a definite class for it, but you read it for your exam purposes.
All 4 of you come prepared with the next MDT. You should answer that's next week only, Tuesday. So speech and swallowing score for all of it.
Function.
And essentially it should be beating around the same thing. Speech and swallowing could be together affected, could be individually affected, the other one could be more affected, the one could be less affected, or the patient is completely not able to swallow at all, but is able to speak. Good possibilities, the various combinations. Why is it? Yes.
So may I ask a question? So how much carotid encasement is resectable, like 270 was considered unresectable?
It's not like the supramesenteric artery. Carotid is a different ball game. It is usually abutting that you can do. If infiltrated, you can't. Abutting and infiltration has to be told by him, which is where CT would be superior and he can actually guide us. Do you think this is an infiltration?
So more than 270 I would suspect infiltration.
But 270 it can't be abutting, no?
Yes,
Why
sir.
should it go all around and around and around?
Yes, sir.
Also we see fat planes.
Okay.
Which is what is abutting and versus infiltration. And flat plane, even between the two, you can't find it.
Infiltration.
We can still get a sheath out. So what they think as, they can tell you to that extent that it is not resectable anyway. So when it's not resectable for one reason, it's not resectable for the other also. If everything was resectable, just a carotid had one 270 encasement of some kind of abutting, I won't take it as not resectable. While in this case, I would add it 1 plus 1 plus 1. Because of this being advanced, this is likely to be
Infiltrating only.
infiltration. But otherwise, isolated lesion, everything is resectable. We have found that we can dissect out and it's possible to remove. And we don't treat the CT, that's another thing. Unlike, I'm sorry, but the other treatments, we are going in and many times a non-resectable that APR patient, the CT wise, you would be, they were all asking how to get a margin. We got it. Because it wasn't as bad as it looked. So never treat a CT, use it. Get my point? So that's an indirect evidence that probably not resectable, not all about it. But he was asking you about anything else. Would you like to have a FNA from the lymph node? What is the status? You're there.
So for staging, we can
So
Clinical
it's not recommended because in the presence of this primary lesion, it will be considered metastatic only. So it won't yield much information
This is how
or
it
change
used to
the
be in
management.
Like in the axilla, people believe now it's changing there also, because they tend to have a lot of infection and there are lots of inflammatory lymph nodes. So therefore, a lot of people may like to do it. The only problem, what is the major problem with FNAC?
So false positive, high false negative results.
So negative FNAC has no value. when you are lost. But an ultrasound of the neck would indicate if the lymph node
Yes,
is
sir.
suspicious. And what are those features?
So if there is change of shape from oblong to spheroidal, if there is loss of halo, if there are central hypoechoic fat necrotic center, and if the fatty hilum gets replaced by a vascular hilum.
Okay, so if you find these features, you can do FNAC, you may not do FNAC, in that case it won't really matter, right? Hello?
Yes, sir.
Sir, also on CT, the size is more than 10 mm for a cervical node and 12 mm for a jugular-digastric node. We considered it involved. There is necroticity is very characteristic of squamous malignancies, and the other thing that we look at is perinodal stranding. So this basically says extracapsular invasion. So if any of these three criteria are present, we label it metastatic on radiology.
And in the presence of this primary, it will be metastatic.
Ma'am, if there is eccentric cortical thickness, then that is suspicious.
So we can look at the radiology right now and we can comment on the perfect. So that we can see those lymph nodes so that it remains in the back of your mind.
Here.
Sir, I'll show you a normal lymph node first. Like this node. This node
नीचे ना
is
जो
normal.
उसके ऊपर क्या है? You can just let me.
Oblong. So this is sternocleidomastoid.
अरे इससे पूछ.
अच्छा.
तब ये लेवल क्या हो गया?
Sir, level 2.
2A actually, to be very precise. I'm improving Amit's system.
If this
2A,
lymph node
2B, how
was
do you
here, it
divide
would have been
Amit?
fine.
Amit, how do you divide into 2A, 2B?
So by the
So
omohyoid,
what I used
the
to
upper
remember
part.
the beautiful notes that Astha and you used to make.
So by the omohyoid,
No. What is Niche?
upper portion is.
No. 2A, 2B divided by spinal
Okay, sorry.
axis.
Yeah.
4A, 4B are divided by omohyoid. ठीक है, याद रखना. चलो, नहीं पता तो
So
बताओ.
this is a necrotic node. It's hypodense. I have a better picture also. See this node.
हाँ, ये रहा.
This
Beautiful.
very big. SAD is at least, this is 1 centimeter. So it is at least more than 10
Cortical
mm.
thickness, that's why Megha asked you.
And
For the
this is the
benefit of
cortical
others,
thickness.
we should all-
This is the cortical thickness. And we can see that that node was homogeneous and this is heterogeneous. Central necroticity. And you can also see that there are some irregularities on the sides. So this is
Excellent, yes.
This node is very characteristic of squamous
So
malignancy.
we don't need an FNAC mostly, and this is the case, it's locally advanced oral cancer. And would you ask for a PET scan?
Definitely, sir. Because whenever there is a T4 plus lesion, we usually do it as well as N2 plus lesion because there are nearly 50-20% times, 20% is the exact figure, the PET CT upstages it. So you find those lung nodules, you find lesions characteristically in other parts, making it.
We have one case where we did it, where a patient came with that, we don't do it routinely. And as per the NCCN guidelines, they don't recommend it as a protocol. So guideline doesn't say that you should do it, but we get your point. Because the problem here is SUV would be, there's a lot of inflammatory element. I agree with you. In a locally advanced case, especially when it's not resectable, would there be any other advantage of doing a PET beforehand? If you're planning to give an alternative therapy?
Evaluation,
raises-
best racist
criteria for
assessment.
response. No. Radiation oncologists.
A question. What do you think would be the most likely terminal event in this case?
What do you think would be the most likely terminal event in this case? What is it that can happen which will actually kill him?
Carotid
Okay. So any therapy that
Don't
we
wait for
institute,
it.
any therapy we institute, we will have to be sure that it may still rupture. Okay. And that is a merciful death actually. So, but still we have to be sure that हम सब कुछ सही कर रहे हैं, dose prescription सही है, chemotherapy की dose भी सही है, but the patient may still die of rupture.
Two cases, and I still remember Pranjal was my PD that time. Pranjal is now a cancer surgeon in Action Balaji. He just saw a patient of He done a neck dissection also in that case. Post RT patient came
What
back.
common? What
It was
common?
slightly only, and the moment he touched it, it was to the roof. And patient just
What common?
Anyway, so how do we proceed? Get back to now the radiology part is very clearly explained that we added this dimension, which is to make it even better, useful for all of you, right? So, PET scan you think would be required? No? Yeah.
We'll probably,
You would want PET scan or not?
If the patient can afford to, I would.
If the patient cannot afford, is it manageable without you?
sir, previously we didn't used to do it.
And when we are looking for the M1 in head and neck, usually the metastases don't happen. We
Sir,
know that.
but
But I'm not trying to say that you don't do it. But suppose we don't have it, can we still proceed?
Sir,
Would it change our management?
Yeah, because if we do a definitive concurrent chemo radiotherapy, the whole therapy cost, and at the end of the day, when after 36 day, 37 day, we find those lung lesions to be there, the whole thing's goes on. And that's in 100 patients and 20
I
patients we
fully
found.
agree. So in this case, for us, you'll have to choose it from case to case. And since you're going to be aggressive in the neck, might as well find out whether you need to be aggressive or not. That's what you're
Yes,
putting in
this
its
is very
perspective.
important because you're going inside with a full curative intent, and at the end of the day, you find out that they are whole lung mets, and then you feel yourself.
We would have actually done damage to the patient rather than anything else. Toxicity and no benefit. Plus the cost. Okay.
The cost of the PET scan sometimes is better than the cost of the whole therapy which we
I
do.
agree.
And
So
that's why,
if it comes out to be M1, what would change?
sir, we'll probably go for a chemotherapy which is less aggressive. Instead of the 3-drug
So
regimen,
it will be
you'll-
less aggressive, more palliative.
More palliative.
Intent would change.
Yes. A TPF
So
type
PET
thing.
can actually change our intent.
Intent, yes.
So the one take home is PET would change our intent in this case, so it's useful to
Do the
PET
thing.
in this case.
Well, will you still go with the curative intent in this case? Because it's
Assess तो करना
unnecessary.
पड़ेगा.
I would like to do an induction chemotherapy for him to see the biological response. Since he said in the beginning it was an ulceroproliferative growth, it looks like to me it's ulceroproliferative growth. Right now I don't have data for tongue lesions specifically for how much of them have become a resectable or how much have they become the chemoradiotherapy. But per se oral cavity lesions, these lesions are amenable to induction chemotherapy, and 30-40% do respond beautifully.
Now,
ये विनीत संकट ने किया था ना, टंग पे तो किया था ना सर.
Vineet की thesis थी उसी पे ही, and he's right. And tongue में, since you mentioned, I attended the Oral Cancer Congress in Toronto. Jatin Shah's team presented a data, and they were of the opinion that you actually can be, especially tongue subset. You're talking about tongue subset.
Tongue subset, yes.
And what I agree with you, PET scan would be required to stage it properly to rule out metastatic disease, and if that is not the case, we will be aggressive in our intent.
Yes.
Because there is response in these patients. In any case, as you said, we'll have an in vivo chemosensitivity to know whether this patient will benefit. Chemoradiation or chemotherapy?
सर इंडक्शन कीमो तो ऐसे केसेस में बनती है
नहीं,
देंगी
देंगी
एंड देन
induction.
उसके बाद कीमो रेडिएशन सर.
That's right.
Yeah.
So the cutting arm would be included, the induction and then moving on. Now, what is the difference between induction chemotherapy and neoadjuvant chemotherapy?
एक पहले इसका
ये बता देते हैं मैंने ना विकास,
ECOG.
ये बता देते
नहीं, मैं
हैं.
पूछ
What is the performance status? You mentioned
90.
90 by Karnofsky. So it will be ECOG how much?
So,
ECOG how much? हाँ जवाब दो.
1.
one.
क्या प्रॉब्लम है?
इको क्या होता है?
Eastern.
Eastern? No.
Eastern Cooperative कौन सी group?
ईस्टर्न कोऑपरेटिव.
Taking up. And it's not European. Now, see, the induction versus neoadjuvant versus primary. Induction is to induce. Right? So is there any difference in the dosage that you use for induction versus neoadjuvant?
We usually use the same doses for that. So 75 milligram.
Primary chemotherapy, then it's a metastatic disease. It's a primary treatment. And the neoadjuvant is when you're planning something like neosports, that channel. So you're putting the patient on chemotherapy, subsequently thinking of some cutting arm, surgery or radiation. Surgery or radiation, but then it can be neoadjuvant radiation also in that case. But if you don't plan it and you're putting the patient on primary chemotherapy, correct me if I'm not right, then surgery that will be done is a salvage surgery which is done for eminent or recurrent disease. That's how you should understand the terms clearly. So induction.
Induction chemotherapy and UHV are the same.
For us, it is.
For us, it is the same. And actually, मैं इसलिए raise किया point कि हम पहले induction chemotherapy लिखा करते थे. Induction chemotherapy was a therapy that you start with. Anything more in the histopathology sir that you would like to say, Dr. Amit?
It could be differentiated from cell carcinoma.
Do you need more information now that we are going to therapy? Nowadays, what has changed in the staging?
Extra
Extra
depth of invasion.
DOI. DOI has changed.
Should be reported on the biopsy.
You can't report it on the biopsy. Would it be helpful to send you a note for more information?
Yeah.
This is all.
No, if you want to confirm that, then
The diagnosis is correct. You can confirm that. Can we get more than this information? We just
the
asking.
core in the node.
Wherever, whatever is there. In the biopsy, this is the maximum information you can
No, I don't
provide.
think so. Any additional information will be gained.
So we have to rely on imaging for things. So what should we do?
So the induction chemotherapy usually consists of the 3 drugs, the taxanes, docetaxel, paclitaxel, cisplatin, and 5-fluorouracil. So what will be the fitness workup would you like to do for the same?
Sir, 5-fluorouracil, bone marrow toxic, bone marrow depression, suppression is there, sir. 5-FU.
Routine blood
And
investigations,
routine investigation,
ECG, and
Echo or ECG?
echo, 2D echo.
जब भी आप
ये
exam
मोगा स्कैन बोलते हैं. That's why I'm asking. Why मोगा scan? We discussed it in your absence. Why मोगा scan?
सर मैं एक बात नहीं बता दूँ पहले कभी भी ना डोंट से रूटीन ब्लड इन्वेस्टिगेशंस प्लीज से
Complete blood count.
Complete.
you say I will ask for complete hematology and biochemistry investigations ठीक है ना
Yes.
कोई भी सीबीसी भी हो ना तो इट इज नॉट रूटीन के आपने ऐसे ही करवाया देयर इज इंफॉर्मेशन टू बी हैड फ्रॉम इट
Yes, sir.
आपका कुछ विजन है तब आपने सीबीसी भी बोला है हमारे यहाँ सब कुछ फ्री हो रहा है आपको पता है सीबीसी कितने का होता है यूएस में
Will do. You got the message, no?
Yes, sir.
$36 का होता है $36 का
So we have to do complete blood count.
Along with biochemistry.
Biochemistry along with message taken. Clearly. And echo is fine as far as Dr. Vikas said because it's comparable. We can use it. That's what we discussed. But if you do Moga scan, you told me something on that day in the OPD which I forgot actually.
सर एक्चुअली
What does it add to?
सर वो वैसे तो बहुत ज़्यादा ऐड नहीं
नहीं,
करता
नहीं,
बट सबसे बड़ा एक हमें फ़ायदा जो हो जाता है बोगा का स्पेशली व्हेन वी आर हैंडलिंग एन इंटरनेशनल ट्रायल एंड दे वांट मूविंग इमेजेस
Okay, you told me this actually.
जो
I
डेटा
forgot.
मैनेजमेंट वाला होता है ना सर वहाँ पर वो ना दे वांट मूविंग इमेजेस ऑफ ऑल इन्वेस्टिगेशंस तो सीटी स्कैन की तो खैर स्टैटिक इमेजेस ही जाएंगी कोई उसमें मूविंग तो होना नहीं है लेकिन आप अगर 2D इको की मूविंग इमेजेस मांगो किसी से तो वो बहुत कम सेंटर्स हैं जो कि कुछ ऐसा कर
So
पाते
for
हैं
that purpose you need it. Otherwise it's okay to do it with 2D echo. Fine. So workup.
Anything more which we discussed last time?
DPD test. DPD test.
Audiometry and quick. We have discussed already this.
This is
G6PD.
G6PD is usually for the iphosomite. DPD is usually for the
Fine.
So what are the 3 mutations we look in DPD numbers? I told you the DPD mutation, but then I thought you should do a homework for
You
it.
were given the homework. Oscar, you very conveniently go to sleep. Right?
For histology also we gave you somebody homework.
All
Let's go. I remember.
Already remember? No? Can you answer that?
Yes, sir.
What is it?
Sir, audit score basically
Kaladana patient 5 out of 8. 5 by 8.
it is divided into two number of nuclei stain
Dr. Amit, you
0,
correct.
1, 2, 3, 4, 5. Then the intensity of scanning of strain, mild, moderate, or high intensity. Up to 3 score is given. Total 8 score is given.
Dr. Amit, how do we standardize these stainings or ERPR, HER2?
Are you talking about the when we are starting the test?
Standardizing it.
So basically we have to do this whole validation protocol is there. So we have to take out cases which are like already reported as positive, and then we take some internal controls which are there like normal breast tissue, and then we have to do all the tests run all these, perform all these IHCs, and then we have to tabulate all the results, and then we can only demonstrate that this IHC is sort of.
Now, what do you titrate it
validated.
against? Like when we validate sentinel biopsy, we do XRD dissection. Like that's how we do it. How do you validate it? Like now ours is a standardized result, because this is what the problem is, variation.
Usually there is most of places.
No, is there a reference point? I'm just asking.
In most of places, it's like 20 cases they take. 20 is the
Okay,
number which they
20.
take. 20 slides they do, and if in 20, which we expect, so we take negative as well as the positive. So there should that there is no false positivity also. So like 20 negative, 20 positive we take, and then once we tabulate all the results, and then it has been seen. Ideally, you can have 2 independent observers seeing those slides, and then once all the results are tabulated, then we can say that this particular marker has been validated, and then we can use it in our
Like it is 30 cases, so that's a good point. I wanted to always know so that they will know it. They've known it now at this age, maybe we didn't know. So it's an information you're getting, and if you can't store it, it's a pity, because that means your picture has a hole at the bottom. So you keep pouring water, it keeps leaking. कई बार मिलने के भी disadvantages होते हैं, क्योंकि आसानी से मिलता है तो we don't value it. So much is on a platter coming to you. People go to sleep over it. It's a tragedy. God makes everyone equal. Where we reach is what you do. Just telling. Yes, sir. You have now you asked last time we discussed it. They've answered 50%. I would have given them only 50%. Now what do you do next? So the regime has told you. The investigations. Anything specific that you want to ask them, and we'll do that.
So right now only you can send me, because I will just clinically how much he is right now, and then we'll take a call whether we'll give the induction chemotherapy, and how do we assess the response again. So I have given 2 cycles of chemotherapy. See, for response assessment, you want to know what should be a primary therapy right now. That's why this whole induction chemotherapy or the neoadjuvant. If the primary therapy is surgery, we would have gone for a neoadjuvant, probably would. But the primary therapy which we are going is a definitive CTRT, chemo radiation, then it's induction chemotherapy. And the PET scan won't do much benefit for it. So we would like to do a local imaging, whichever is.
I was asking you the same question, because we come back to the point. Whenever I'm conducting a panel discussion anywhere, this is a question I always ask, because a lot of our patients can't afford it. So we should be able to manage them in spite of that. So the regime you mentioned is for induction chemotherapy, and then you'll see the response. And what probably you're trying to say, the imaging that we used before, your thesis was a neoadjuvant chemotherapy only, so we published it in British Journal of Radiology, good impact factor journal, we published it, was beautifully done. So the same imaging modality has to be used subsequently.
Yes.
Now you take the responsibility of the imaging for this patient subsequently.
Sir, I would, since to better assess the tumor size, I would like an MRI.
Ask for an MRI, and you would also want an MRI.
Not right now, because my therapy won't change it. It will add a cost to it. I
Because
would
the
love
light
to
can
have
only be compared with light.
See, mostly, what I'm
sometimes-
saying, look, for the same reason, the racist criteria concept as it came in, what is the earlier criteria?
So it was WHO criteria using 2 of the
Different
dimensions
dimension, median
and
of that.
mean of
Single,
that. Dimension is the
therefore
recent
they use
one.
what imaging?
So
Mostly MRI.
MRI.
So MRI would have been ideal, but we have this now. So can you use CT to assess?
We can, sir, but it is very hard to
Please come,
differentiate
Dr.
between
Kadaria.
fibro.
So, yes, so we'll start with the induction.
induction chemotherapy and then see the response. And then at the same time, I would ask my colleague to have and make a planning for him at it. But would the planning be, so we did a CT, whatever the head neck malignancies we discussed last time, the surgical margins don't change. It is based on.
Head and neck?
Sorry.
My footprint will
His
remain just the same.
plan would change depending upon the response. So should I send him on the day 1 or should I send him on day 60?
No. His plan. Surgery margins are not changing. Would radiation margins change?
No, sir.
Just relax. First of all, question to सुनना चाहिए तुम्हें दिक्कत हुई. The surgery and radiation are cutting arms which work on the same principle. I am sure he'll agree with you. So the margins will be the old footprints. So all it helps is in reducing the edema. A lot of induration would go. Maybe the margins, the true margins would appear. But radiation would cover that. What field you would cover the radiation? In this
सर
case?
तो सीटी पे प्लान करना अगर आज की ज़माने से आइडियली इफ यू डू देन वी शुड यूज कन्फॉर्मल रेडिएशन. तो उसमें तो सीटी बेस्ड प्लानिंग होगी.
How about the neck?
नेक तो सर फुल नेक जाएगी, नोड्स सारे कवर करके ना.
Will that take care of the-
वन स्टेशन बिलो द इन्वॉल्व नोडल स्टेशन. उसको तो फिर उसमें ऑलमोस्ट फुल नेक चली
We are
जाएगी.
hesitating to say that they don't know. That's why I was bringing it out. One station below the involved
Involved
node.
node.
And how about the contralateral side? Will it be covered in exit RT or you'll give some dose for
No,
that?
sir. It will be parallel opposed fields. So both sides, we will have to give a midline dose. So we will give equal doses from both the sides. Understood?
Okay. Morbid.
Morbidity तो है सारा.
Would we need, I mean, you should have asked or I'll ask him now. You should be answering. इसको हर बार खड़ा कर देते हैं हम लोग. What do we do? Because when patient will be subjected to chemo and also then chemo radiation, he already talked about SNS, so speech and swallowing. So what do we do about the nutrition?
So we would like to put a nasogastric tube.
Or something which is better than this?
Feeding jejunostomy.
Jejunostomy is better than that. Disconnects the whole thing?
Yes, sir.
और क्या?
Upper part.
और क्या होता है? Peg.
Peg. Percutaneous.
Just the way. You have to use an enteral feeding.
Feeding.
PEG is relatively less morbid. But it has its problems. What are the problems of gastrostomy or jejunostomy? So the question is surgical.
Regurgitation chances of
It's called aspiration.
Aspiration
It's not
chances.
regurgitation. Aspiration is more. That's why it's all gone out of use. Earlier we were doing gastrostomy. I've done, and all the names that you talk about, Stam and Witzel,
Yes, sir.
they're all gastrostomy. They're not jejunostomy. उसको उसमें भी use करते रहते हो. The feeding jejunostomy is superior to feeding gastrostomy, and especially for the when you're doing in the cricopharyngeal and below, when you're going to use stomach for pull-up or whatever. In any case, it's very useful. Anyway, you need to take care of enteral nutrition later on, which will be a problem because as he would start with radiation, Sika syndrome, which was discussed last time. And for the
Anyway,
better.
chemo radiation, if we institute in a patient like this, we have to be very careful regarding the hydration. So at the slightest, we have when we start the radiation, we have one SR stationed in the department where the therapy is being done, and that is called reaction clinic. Okay, so we promote that every day the patient comes and reports to that resident, usually an SR level person, and he checks the reactions because this is mucosa. So the patient will definitely have severe oral mucositis.
Mucositis, yeah.
Fine. So at the slightest hint that this patient will become compromised, we admit them or we give them fluids. Okay, IV fluids. So unless we do that, it is impossible to go to 70 gray kind of doses. Nobody can tolerate such high doses.
That's why she was
And
asking, will you
that
still
liberal
be
upset.
curative and aggressive, but then that's the
इतना
only
बड़ा
option.
इसलिए काफी बड़ा फील्ड होगा तो इसलिए
Not only that, we'll be giving them cisplatin also.
Cisplatin तो होगा ही
So
सर.
kidney will be severely compromised.
You need to have, yes, to
बहुत
hydrate.
aggressive hydration करना पड़ता है.
Addition part is too very.
And in fact, we have seen that if we promote hydration more, the patients go through radiation smoothly. They have less mucositis. Okay, so we have to promote oral hygiene. So liberal use of mouthwashes and all these things, soda, saline, gargles. Understood? So if all these things is done, then radiation and even chemo radiation is quite easy.
Because actually, they used to have this Zyte gel earlier. It's gone now. Is there any replacement for that? Because the patients keep coming.
बहुत सारे आते हैं सर, बहुत सारे.
Which take
एक
care of
सर
the
वो आ
pain.
गया है कैल्फोरिन्स सैचुरेटेड कैल्शियम का वो आता है That is very good for this thing, oral mucositis. Zydus का है और फिर सर L-glutamine का के sachet आते हैं. They are also very good for oral mucositis. Chemotherapy induced में भी बहुत अच्छा काम करते हैं सर.
And this reaction clinic is a very good thing that they should know.
We are using what we are using as a it's a mixture. What we do is we take boroglycerin.
Boroglycerin.
100 ml of boroglycerin. We put 2 capsules of metronidazole, 2 capsules of Septran, and 2 capsules of Imidine. We make it a paste.
2 capsules last क्या?
The clotrimazole.
Clotrimazole.
So it's a basically a mixture.
So also लोग इस पे apply complex भी add करते हैं.
And we apply it.
That's the most simple, most easily available thing.
We apply
We use
every
it as a
4 days.
baking
The
paste.
patient should not rinse after you apply that paste. And it's very effective.
I have a patient just going to do OPD. We'll do that. याद रखना इसको हिंदू.
All of these things, what we are trying to prevent. See, when you give a definitive therapy, be it my therapy, be it his therapy, 30% of patients don't complete the therapy or have a morbidity or mortality because of one term that's known as aspiration pneumonia. So hydration, weight, mucositis, all these things.
Head and neck patients especially, you're right actually.
And then we are landed up in the soup. You wanted to went into curative patient, but the patient died of aspiration pneumonia before completion of therapy.
Next, can you take the next case? We have 4 cases.
Good afternoon, everyone. I will be presenting case of Mr. Anil Kumar, who is a
So,
47.
last time
Year-old gentleman, belonging to lower middle socio-economic status, resident of Allahabad. The patient presented to Sabrajan OPD. He was referred from Rajiv Gandhi Cancer Institute. He was apparently asymptomatic 6 months back when he noticed a small swelling in the left buccal mucosa, which was insidious in onset and progressive and ruptured spontaneously 2 months back following an ulceroproliferative growth which developed in the left lower gingival buccal sulcus, gradually increasing in size to the present size of approximately 4 by 3 centimeter. It was associated with pain and difficulty in mouth opening. There is history of artificial 2 upper and 2 lower incisors approximately 7 years back, and the patient is a chronic tobacco chewer and alcoholic for past 20 years. There is no history suggestive of metastasis, so there is no other comorbid conditions and no similar complaints in family. On general physical examination, the patient was alert, cooperative, conscious and oriented to time, place and person. Performance status was 90 by Karnofsky. He was well built with adequate hydration status. There was no pallor, icterus, cyanosis, clubbing, pedal edema or any generalized lymphadenopathy. Head and neck examination. On inspection, the patient was examined in sitting position. Left-sided facial swelling was present. Mouth opening was 2 centimeters. Nicotine staining of teeth was present. There was halitosis, submucous fibrosis was present, and tongue appeared to be normal. This is the image which shows edema over the face, left cheek.
I'm sorry, I lost in between. You said ruptured something. What ruptured?
Sir, there was lesion in the oral cavity, but externally, sir, there is visible facial edema on left side.
So there was an
Where did
ulcer
it
inside.
Rupture you mentioned. No, he's asking how did the ulcer rupture?
Rupture क्या हुआ था?
Sir, buccal mucosa, sir, inside the vessel.
No, it ulcerated. No?
It ulcerated.
So rupture थोड़ी ulcerated होती है.
I lost the flow of contact.
No,
That's
you
why.
did definitely, and I think slides can be better. Make bigger ones. Okay.
The oral cavity examination, there was ulceroproliferative growth of approximately 4 by 3 centimeter in the left lower gingivo-buccal sulcus extending from the angle of mouth till the retromolar trigone area. So the growth had well-defined margins with everted edges, irregular surface, and there was slough present at the floor. This image shows
Show it
restricted
tilted
mouth.
वही रखे tilt कर दीजिए.
So restricted mouth opening with poor oral hygiene. So there is growth present in the left-sided lower
Is
gingival
it
buccal
cheek or
sulcus.
gingivobuccal sulcus? It is gingivobuccal
Yes,
sulcus.
lower
No?
gingivobuccal
Which is a different
sulcus.
cancer. Okay.
So extending from the angle of mouth till the retromolar trigone area. So on palpation, there was 4 by 3 centimeter ulceroproliferative growth present, which was tender and firm in consistency, leads on touch, and the base was indurated. So on local examination, level 1B and 2 ipsilateral lymph nodes were palpable. They can also be visualized again.
Yeah.
So on histopathological examination, there was,
What was the size of those lymph nodes?
sir, it was around 2 by 2 centimeters. Sir. So on histopathological examination, it showed moderately differentiated squamous cell carcinoma, and the patient had PET MRI, which showed left buccal. Yes, sir. In Rajiv Gandhi Cancer Institute.
Don't repeat the institution's name repeatedly, that's okay.
So left-sided buccal mucosa growth, buccal mucosa shows ill-defined enhancing hypermetabolic altered signal intensity lesion in molar to canine region, 5.9 cm anteroposterior, 3.4 cm transverse, and 4.5 cm craniocaudal. So the masses involving lower gingivobuccal sulcus, retromolar trigone, underlying left lower alveolus.
इसको ऑन तो करो.
Left lower alveolus in premolar, molar region, ramus and body of mandible with medial extension into the left sublingual region. And superiorly it was extending to the upper gingivobuccal sulcus and anteriorly involving the angle of mouth and orbicularis oris muscle. There was enlarged partially necrotic hypermetabolic lymph nodes in left upper deep cervical region, largest measuring 2.5 by 2.1 centimeter, effacing the IJV and abutting sternocleidomastoid muscle. Rest of the oral cavity, including the bilateral tongue, appeared normal. This is the PET scan.
You should have discussed it with. Did you discuss that with? Okay. Now you can talk about it, expand it and tell us.
So this is a PET CT and not a PET MRI. This is a PET CT. Look at the image. This PET CT. One very good way to see whether this is CT or MRI is to look at the spinal canal. So if on a T2 weighted image you see bright signal there, then it is MRI, and on CT you will never see that. So we see a PET positive large mass lesion involving the left-sided gingivobuccal sulcus, and obviously the mandible appears to be involved by the lesion. Apart from that, there is a level 2 node. That's pretty much it actually. So the lesion, this is the lesion. So one more thing I would like to say is that with due respect to the institution the patient came from, the scan should have been performed in a puff cheek maneuver. So because
Yes, we discussed last time, puff cheek maneuver. Tell them why, Amit.
Because if you don't puff the cheeks, both the gingivobuccal sulcus is collapsed, and if you inflate it with air, you cannot see. If you don't inflate it, you cannot see whether the buccal surface is involved or the lingual surface is involved. So it's very hard. So always puff cheek. So we can see that the mass is involving. This is the left gingivobuccal sulcus mass. This is the superior section. It's extending up to the maxilla. It is involving the mandibular alveolus. On the lateral side, it is not involving the skin, and it is also extending into the masticator space. The left-sided masticator space. So this masticator space is a space which encloses masseter muscle, temporalis, and both the pterygoids. Apart from that, it also encloses a small amount of fat. So if you can see this portion is fat, hypo on CT, and this is the masseter muscle. Do you see a small line which comes ahead of it?
Yeah.
So this is the antral or buccal fat pad. So this is also a part of masticator space. I said that the masticator space is involved because I cannot see this fat pad on the opposite side. So posteriorly the lesion appears to extend into the left tonsillar fossa again, and obviously the retromolar trigone is completely involved. If I had a better picture. This is the only image? Yeah. So this is the retromolar trigone. This is the trigone on the normal side. So this fat space is normal. Anything which comes in this fat space is abnormal. So we can see that there is a soft tissue lesion involving the retromolar trigone.
Oscar, clear now? You were asking yesterday.
Can I ask you a question? Why is the retromolar trigone important?
No. Change staging. Why retromolar trigone is surgically important?
it is surgically challenging to.
It becomes
Why?
T4B, unresectable. So because of the involvement of pterygoids, because of the involvement of the pterygoids,
Why is
it
the
becomes.
pterygoid involvement?
So attachment to the skull base, so it
Effective
indirectly
skull base
involves.
involved. ये तो आपको तो कोई पता नहीं की बात है रोज
From where all the tumor can spread from the retromolar triangle.
From the retromolar trigon, it can involve the skull base and through foramen magnum and other foramen.
That's going too far, infratemporal.
Infratemporal fossa.
So actually it is very easy to see on this image and it is very easy to remember. So this is the retromolar triangle. If it goes laterally, it involves the buccal space. If it goes anteriorly, it involves the tongue. If it goes posteriorly, it involves the tonsillar fossa. If it goes, it can involve the mandible obviously. And obviously there is a pterygomandibular raphe on the posterior aspect, so it can go ascend upwards. And,
Which is the usual direction? It has to be the path of least resistance, so I've given you a hint. Backwards.
Backwards.
That is why they are difficult to resect in that position. And you should instantly answer that as a surgeon. That means the skull base is involved. And that will be already presenting as trismus. While trismus is also not considered non-resectable now. Which trismus can be resected? He mentioned about the masticator space. So masseter involvement can be managed, but the pterygoids are a contraindication. So you should understand that. And why does it become painful? The spasm of these muscles. So trismus is a painful restriction of mouth opening. Otherwise you can have restriction of mouth opening due to painless conditions like summicus fibrosis, many other conditions. Anyway,
so whenever the mandible is involved, we would like to say that whether the condyloid fossa, whether it is the lesion is extending up to the condyloid fossa or not, because I think it is important surgically.
please show that.
The best thing is to get the CD because it will. You have
Yes.
got the CD because he will be very very comfortable.
Yeah.
है CD?
सीडी आपके पास सबको समझ में नहीं आया उन्होंने क्या कहा यूजली वो सीडी देते ना तो सीडी इसमें लग नहीं पा रही है तो उसको पेन ड्राइव में लेना था फिर इधर प्रेजेंट करना था नेक्स्ट टाइम ऐसे करेंगे आप
Because then he can show you the live things, how the lesion is spreading
they will
upwards.
next time discuss with you one day before so you can tell them to get a CD.
So like and posteriorly we have the condyloid process which articulates to form the temporomandibular joint. So if this notch is involved, then it is unresectable. So we take a criteria from 2 centimeter to the skull base. From 2 centimeter to the skull base. So if this area is involved by the tumor, then it is a supracondyloid invasion. And if it is not involved, then it is infracondyloid invasion. Another thing I would like to add is the pterygoids, lateral involvement of the lateral pterygoid is supracondyloid. Involvement of the medial pterygoid up to the first 2 centimeters is supracondyloid. But the pterygoids extend for up to 3 centimeters. So from that 2 to 3 centimeters, it is infrapterygoid. It is infracondyloid. So whenever this only we say whenever the mandible is involved. Because I think there is a segmental mandibulectomy and then there is a mandible.
What again? Talk about when you see the resection being done. He's talking about this zone. And when we are resecting the mandible, you must have seen we have to cut the muscles here. They are all attached here. If it goes in this plane, it is not resectable. And he's talking about skull base 2 centimeters. Am I right?
Yes.
Anything more?
No, sir.
So based on this, it's more or less similar to the previous one.
Yeah.
But could there be any difference? Tongue versus gingival circus?
The growth, I think so. It was involving the masticator space and it was retromolar triangle involved. And how much is the superior? Was it involving the ITF or you don't think so it was?
Sir,
Because we couldn't get it in
ITF appears to be involved, sir, because it is involving the pterygoids.
So,
So where's the ITM?
ITF is masticator space minus masseter.
Sorry, same abhi jo bataya.
Yes, sir.
so very important finding in this is you've got You didn't mention in one thing. I am very particular about it. That's the edema. Where was the edema extending to it? So
we tried to say zygoma, but I think it's not going that far. Show the picture. He said that actually, incidentally.
It appears to be the mass which caused the swelling. By looking at the CT images, I'm not
No,
really-
with the edema going into zygoma, no?
Yeah.
We suspect it to be infratemporal fossa being involved. And infratemporal fossa, as you rightly said, you included in masticator space macitrin in addition, actually, although it won't bother us. The part that bothers us is minus masseter, which is what is basically infratemporal fossa. And that's the area we talk about. When you showed that progression into the medial and posterior space, posterior medial extent is what is
There's no infection part there, is it?
Ah.
I don't know, it looks like, doesn't look like lecture.
Exactly. Induration
Yeah.
is
Maybe you can give a course of antibiotics and see.
it might settle. But actually, the growth being so far as it is,
inside it, yes.
so inside it has gone too far. So there is no rupture business here. There was a growth in the gingiobuccal sulcus, which is waiting to ulcerate through the skin. And it's getting
probably
close to
coming out.
surgery. It's coming out soon unless we do something. And that's where even he would be interested. Radiation can be a challenge. Surgery is what they look at as the best modality in most cases. But in this case, you won't get a clear margin because pterygoids are involved. That's our catch. So that's where maybe you can use his help for downsizing or staging it so that we'll still do the same surgery, but we can actually do it. If you don't get a clear margin, then
But this case, I think probably induction chemo followed by.
chemo followed by surgery. And the dose, will it be different from tongue anyway?
No.
It is quick, then
75.
So induction chemotherapy followed by surgery. You don't need a PET scan for this. You already have it.
No, but we don't need CT chest alone is good enough.
Good. That's the point. I agree with it. Time was made to do it.
There was the nodal disease I'm very afraid of. When it goes to the node, and plus it is and 3 specifically, we look for getting a must of PET
Absolutely.
scan.
When is it mandated to have a CT thorax in head and neck cancers?
So level 4.
Nodal mass
Yes, sir.
and heavy burden, N3 disease. And they now talk about the depth of invasion, etc. Those features also come into play. All bad prognostic factors that you can think of. Thoraxis. Why are you wanting to do CT thorax?
Metastasis.
So it was believed earlier that oral cancers don't go to far places. They don't still go to far. They locally are the responsible. So this is the case. We can move to the next case. Can we? It's not buccal because I still know buccal buccal because it's a different cancer. Treatment is
It's
different.
induction chemotherapy plus chemoradiation for ductal cirrhosis.
That's it.
The pterygoids weren't involved for him. Edema is still below the zygoma. What would be your surgery you would like to do? Then
He's trying to say, we'll put it to a surgeon the way they understand. He would say it's a resectable disease.
it is a resectable disease.
What would you do? We'll do what?
Wide local excision of the lesion with 3-dimensional clearance with
Let's see
1.5.
the three-dimensional clearance, it would be a wrong answer. So just wide local excision is not a correct answer. With three-dimensional clearance, margin how much?
1.5 centimeter.
With?
1 to 1.5
It
centimeter.
will be composite resection.
Yes, sir.
What is composite?
So in which the soft tissue as well as the bone is resected.
And in this case, it will be mandible. We won't be able to preserve. We'll do segmental mandibulectomy versus hemi-mandibulectomy here.
It's a segment.
It's always a segment, depending on how much you need. It can amount to hemi also. Those concepts, those.
Yes, sir.
And what else?
So along with right-sided modified radical neck dissection type 2 and followed by reconstruction.
Type 2 would be.
So if we preserve spinal accessory nerve and internal jugular vein.
So, will that satisfy?
Perfect.
And
Will you take the
reconstruction.
graph?
You didn't finish.
So I did. So I just
You
mentioned
did what
reconstruction. So
You've taken out
bone
you've
as
taken
well
out
as
muscle,
the
you've taken out
muscle.
skin.
So osteomyocutaneous flap using.
No grafts here. Flap. There is no graft in
No, sir.
reconstruction. Graft is useless. Which flap?
So pectoralis myocutaneous along with the rib can be taken for reconstruction of the
flap, which
mandible.
one?
Fibular free flap can be used.
Which is osteomyocutaneous. If you
Yes,
don't say
sir.
osteomyocutaneous, it won't cover it up. Text.
Sir, in our books it is written that if 1 centimeter of the mandible is spared by it's not involved, then the surgeons can go with the segmental.
Radiologist को क्या पता क्या वहाँ पे क्या चलते हैं. The 1 centimeter is CT. When we are going in, 1 centimeter is impossible to measure. So when they all saying 1.5 centimeter, Megha gets verified. She's been there longest with me. You take at least 2 centimeters. She also. हम वाइडर ही जाते हैं और हम मैंडिबल एक्स्ट्रा लेते हैं. मैंडिबल मॉबिलिटी नहीं है हमारे लिए. बाद में वैसे भी ये रेडिएशन के बाद उसकी हालत ऐसी खराब होती है, वो मैंडिबल किसी लायक बचता नहीं. पहले वी यूज्ड टू रिकंस्ट्रक्ट यूजिंग अ प्लेट एंड डॉक्टर Bhavik told me once, please don't put plates, I won't give radiation. He got very angry. I'm talking about 90s. I said, why did you get angry? I'm fixing it up. Can you see the plates you are using? We're using the cheap ones. There's bouncing of radiation and collateral damage. They said, you use the synthetic ones. Synthetic ones are costing fortune. So we started leaving it alone. And leaving it alone fixed. I think they're fine later on. They are just, there's pseudo-arthrosis. False joints form. Oh, बढ़िया रहते हैं. Or the other option is rest of the mandible can be approximated. This falls into place for some time. It falls into place. But as long as the margin is clear, the mandible can be saved. But we are not achieving much by saving mandible in the posterior segment because it won't help in the chewing, mastication. But the symmetry of the face will be maintained. The only problem with reconstruction is radiation. Even that osteomyocutaneous flap suffers from the vessel suffering, the feeder suffering, but PMMC is a very correct answer because the pectoral branch of thoracoacromial artery, which is the second axillary artery, second part branch, it is a steady one. Like LD flap we have, this doesn't suffer so much. Free flaps don't suffer so much because the vessels are strong and stout. Otherwise, the bone तो खत्म ही रहती है. PMMC के साथ जो rip use करते हैं ना हम लोग, rip तो टूट के बराबर radiation के बाद. They cook everything, including the bone.
वो जो फर्स्ट बोला था ना बाउंसिंग ऑफ रेडिएशन, दैट इज नॉट एग्जैक्टली ठीक है. टू एक्सप्लेन टू द सर्जन इट इज स्पोकन दैट वे, बट आई थिंक यू कैन अप्रिशिएट जैसे
Scatterity.
हाँ सेकेंडरी इलेक्ट्रॉन्स.
स्कैटरिंग तो फिर भी
स्कैटरिंग तो होगी ना सर.
हाँ सेकेंडरी
इलेक्ट्रॉन्स बनते हैं, दे आर लो एनर्जी इलेक्ट्रॉन्स. कुछ नहीं करते, वो लोकली हो जाते हैं डिसिपेट और दे जस्ट कॉज इंक्रीज इन रिएक्शंस. दे हैव नो थेरेप्यूटिक वैल्यू.
Exactly. Scattering effect, yes. Next case, the change.
I'm here to present a case for the
You
MDT.
speak loudly.
Yes, sir. So, the case was of a left breast carcinoma managed by Benelli's round block mastopexy approach. The patient's name was Kanchan Sharma, a 38-year-old female, resident of Delhi, a premenopausal and housewife by occupation.
Male and female is not the box. 30 years lady and 30 years gentle. Male female जो यूज करता है हम उसको respect खुद नहीं. And especially my PG don't do. You don't do.
So, within the presenting complaints of the patient, the lump was present on the left breast since 2 months. It was present in the upper inner quadrant of the left breast with no history of increase in size. It was associated with dull aching pain. There was no history of any discharge, no history of any other comorbidities within the patient. There was a history of skin grafting done following trauma to the dorsum of the left foot 10 years ago. There was a history of tubectomy done 2 years ago. The patient was a para 2 live 2 abortion 1 status, which had happened at 2 months of gestation. On examination of the breast and the axilla preoperatively, the left breast had a 4 by 3 centimeter lump, which was present in the inner upper quadrant, which was firm to hard in consistency, which was non-tender with no active discharge present, not fixed to any underlying structures or the chest wall. The left axilla also showed a 1 by 1 centimeter small lump present, which was present in the yes, sir. Sorry. The right breast was within normal width. There was an ultrasound done for the breast preoperatively, a nodular hypoechoic lesion measuring approximately 12 by 9 millimeters approximately, left axilla, celestial lymph node was present. Lobulated lesion, mildly like irregular outlines and measuring approximately 36 by 22 millimeters was seen in the left breast. An MRI of the bilateral breast was also done, which was suggestive of an hyperintense lesion seen in the upper medial quadrant of the left breast, showing restricted diffused heterogeneous contrast enhancement with type 2 and 3 dynamic kinetic centers, suggestive of Birad's 5 staging. Sir, a core needle biopsy was performed.
MRI क्यों किया?
Sir, बाहर से उठाया.
नहीं कर क्या है, हम रूटीन में जब ब्रेस्ट कंजर्वेशन करते हैं ना, some people like to do it but to rule out multicentricity. But I agree with you, and he'll bail me out. MRI is super sensitive, so it picks up too many artifacts, and sometimes breast conservation becomes difficult. So as a protocol, we don't do MRI. There's one case where we're planning to do it. We are thinking of MRI because equivocal diagnosis there. So it's a problem-solving tool. But here the patient brought the MRI.
And why was it ultrasound breast then, or it was ultrasound axilla then?
Sir, breast and axilla both were done, sir. So that was
They
done
did
outside.
a mammo ultrasound would be there, no? Mammosonography was.
Sir, no, sir. Ultrasound.
Why did we do the mammosonography?
Why did we do an
So
ultrasound?
we didn't know it, the patient presented.
Why do we do an ultrasound?
So because in AGCC 8th edition, now the end staging depends on clinical as well as ultrasound.
You can't clinically stage it. So we do that as a routine. और ये immediately bail out.
Patient is intelligent enough to do investigations which are very
ठीक हो
proper.
गया है, तो ये भाग रहा है.
एज क्या है की?
We have conserved data in
मैमोग्राफी में नहीं होता ना फिर इतना अच्छा, इसलिए मैमो यूएसडी होना चाहिए था.
Why? What do you need? What do you have to say? Because some patients go and we will not be doing a 30-year lady mammogram anyway. So ultrasound is not very sensitive. The MRI becomes the automatic choice in this case. Do you agree?
Sir, 30-year-old obviously no mammography. We can go with MRI, but MRI is very sensitive,
Like I
but
said,
not
no.
so
Well,
specific.
there is only for
So you see,
patients which are borderline.
Now,
Sir,
what
you
the
see
If you
that
already have
point
a
is,
clinical
Dr.
nodule present, then what?
Now ultrasound to what? Because ultrasound is sensitive but not is specific but not sensitive. MRI is sensitive but not specific. Am I right?
Yes.
And when you were undergraduate, I used to teach, which I have taken back a few of these words, that ultrasound is a poor man's MRI and MRI is a rich man's ultrasound. Because then although MRI is what are the indications for MRI in otherwise situation? One is problem solving. Any other?
So if it's a high-risk patient with a strong family history,
BRCA1, BRCA2.
BRCA1 breast,
And also
Implant.
implant,
implant patient. And also
for the scar recurrence or
also lobular carcinoma.
lobular carcinoma.
DCIS is seen very well with MRI. In fact, that's a problem.
response evaluation.
Response evaluation is the other indication. This is what we do it for. So that's why the question is valid when I asked you. Would we have done with ultrasound alone in this case?
Yes, sir.
MRI didn't
Ultrasound followed
anything.
by a biopsy which shows.
Biopsy is good. See, you get the point. You used to come for Chandrasekhar's thesis, no?
Yes.
When we were measuring with putting the dye, you used to come with ultrasound on the table. Ultrasound can give you good enough information. Not any limitations of ultrasound in terms of course, operator dependent, but otherwise, in this case, to make a diagnosis. As a part of triple assessment, can ultrasound replace MRI and mammogram? This is triple assessment, it's a diagnostic test. We are not doing for screening, so let's not confuse the
Sir,
two.
I can't think of any disadvantages of ultrasound.
If he is doing it, there's no disadvantage.
It's a superficial organ, so the rays pass and you can see everything.
Okay.
See, plus mammogram you have a documentation. When USG you won't get, it's only for operator dependent. So next time somebody is doing it, he will not be able to get it.
Exactly, I'm saying that the operator dependent is an issue. Mammogram is
So documentation, I agree with you, is very important.
now
Because-
any situation where you do a mammography is younger patient. There is.
No, this patient already had a palpable 2 centimeter lump. So
already a tumor.
that is enough.
When it's diagnostic.
Mammogram
Screening
is
is a
enough.
problem. So the protocols have to be looked at carefully. In a very, it's a very sensitive, very useful, sensitive and specific mammography. But here we did, it's a smallish breast if you look at it. That's why we went for conservation also for the same reason. आगे चले थे इसमें कुछ anything here?
So the core needle biopsy that was done was suggestive of infiltrative ductal carcinoma of the left breast. The modified BR score was 6 of grade 2.
Plus 2 plus 2 plus 2.
What is PR?
हाँ तो क्या आगे क्या होता है?
Okay, 2 plus 2
कंपोनेंट्स क्या होते हैं? कंपोनेंट्स क्या होते हैं इसके? पहले बताओ ये मॉर्फोलॉजिकल स्कोरिंग है कि किस टाइप की स्कोरिंग है ये?
Mitosis and nuclear mitosis.
Sir, number of mitosis, nuclear grading scores.
Or
Size of the
Nuclear pleomorphism.
Pleomorphism and
Tubule formation. Tubule formation.
so what are the three? Repeat. You just complete.
So tubule formation, nucleoli, number of nuclei, and number of mitosis.
Okay. Ki 67 less than 14%. What does that mean to you, Vinay?
So the proliferation was less.
Low. And what does the tumor look like? ER/PR positive, HER to new, biological.
ER positive, PR negative. अच्छा.
Yes, sir. So this was pre-operative. We see.
हाँ,
It's
कोई-
okay. इसी बात होगी.
So surrogate molecular classification luminally.
You are happy with that? No? ER positive, PR negative, will still be ER positive.
हाँ, ER positive.
That's right. And HER to new, negative, 1+. So it will not be called expression. You will not go for fish unless it is 2+. So
How
we
do
can
you
take it as
grade
a-
it? How do you grade it? It's grade 1, grade 2, grade 3. How do you know that?
HER की कैसे करेगा?
नहीं सर वही
It's
grade
a grading of a tumor.
grade 2.
अच्छा, MDR.
Because see 4 centimeter presentation, we would think it to be a grade. I always feel it very confusing. How do we differentiate between grade 2 and grade 3?
No, the scores are there, no?
So based on that
score is
See,
8 or
last
9,
size
then we call it
won't be
grade
having
3.
a great impact on the grade per se. And sometimes you find large tumors doing very well, and small ones being terrible. So grading, is the broadest grading disappeared completely or you still use it? We don't
We use
use
this only. So we add up the scores. So if it is 8 and 9, then we call it grade 3. And if it is 5 to 7, we call it grade 2. And if it is less than 5, we call it grade 1.
So we take that. That's coming from the final diagnosis. Mr. Pearson is saying it. Final diagnosis pathologist.
Sir, is it possible to do an IHC after giving chemo and RT?
It is.
Possible तो है, but it is not very reliable.
That's what I read actually.
There's some markers that
Affected by
change. Some markers we've done studies and even ER/PR and also AR, which we did, where it can change. We looked at it and there's a very interesting study done with JP. JP को तो जानते हो? तो विनय के apoptotic markers था फिर JP का था. तो JP का अपने AR P glycoprotein. तो उसमें वो before chemotherapy P glycoprotein is a predictor of poor outcome, poor response to chemotherapy. So we found out that all those tumors that are P glycoprotein negative, they were good responders. It's essentially colonic में पहले होता था, हमने breast में किया. So of the 30 patients that we had, 16 were responders, 14 were non-responders. That is, and they were very classically positives or non-responders. It worked very nicely. But after 3 cycles, the numbers changed, and the response also correlated. So there is an acquired chemoresistance, and how does the tumor know it all? I don't know. We are trying to know, but tumor already knows it. अच्छा, तो peak glycoprotein we change करना. They became many of them became peak glycoprotein positive, and suddenly the response is reduced. And acquired chemoresistance, I have never studied better than in that case. That study itself, we published at least 4 papers based on understanding of it. And JP was very good PG in that sense because he said, sir, अभी जो देख रहा हूँ, वो जाके देखता था उसकी staining ICMR के साथ. We found that many P glycoprotein negative tumors became P glycoprotein positive after 3 cycles, like a virus does. So that's what a very smart cells, tumor cells. Anyway.
While in the management, we manage the patient with a left Benelli's oncoplastic breast conservation surgery done with ipsilateral sentinel lymph node biopsy as well as axillary lymph node dissection with axillary drain placement. So these are the.
Can you just blow it up to show them because they are not seeing it every day. You think this is round down donut created next.
Yes, sir. So for a peritoneal incision taken for deepalization, plane created in which the lump.
Mastectomy plane, we took the lumpectomy
Yes, sir.
done. That sentinel node biopsy already done.
Yes, sir.
And
So-
we have a help of pathologists. Now
Yes,
they
sir.
give us the imprint. So we are able to take a decision then and there. And one margin was doubtful on the medial side.
So,
तो क्या दिखाने की कोशिश कर रहा है? वो है तो उसी उधर ही उसी को
sorry. So,
बड़ा इसको can you blow it up?
Last one.
The last one, sir. This is how it looked after surgery.
the outcome.
She came yesterday and yesterday's picture is there.
So actually, I have my phone. I received from them so today morning only.
No, but picture was taken by us also.
Sorry.
It should have been put in the slide. 2 weeks, 3 weeks.
So this is 2 weeks. Outcome which is very favorable.
Good.
Yes, sir.
No. You can come to the notes because that is what you're waiting to talk about.
Yes, sir. So in the intraoperative findings,
Loudly.
There was a 3x4 centimeter lump which was present within the inner upper quadrant at 10 o'clock position. The intra-op imprint cytology of the margin was done. A microfocus was present on the lateral margin, for which a cavity shading was also done, which came out to be negative. A sentinel lymph node biopsy was sent for imprint cytology.
It was medial, I think.
It is medial margin, then we shaved off the.
It was mentioned that.
So lateral part, medial quadrant.
It's a
Actually,
lateral.
the tumor was present on the medial.
No. Margin.
The tumor was just an inner side, so it's a lateral margin.
Towards
the nipple, sir. Lateral nipple.
So, acha, margin lateral towards the nipple. That's right. You're right.
So in the sentinel lymph node biopsy, which was sent for imprint cytology, was also positive. The axillary vein, thoracodorsal pedicle, nerve to serratus anterior, pectoralis major and minor were identified and preserved. Axillary lymph node levels 1, 2 and 3 were dissected. A circumarular incision was sutured in monopole sutures, as well as the axillary incision was closed with nylon. We received a histopathological report yesterday where the patient had presented with it. From pathology side, there were 6 containers received. The first container was of left breast lump, which was received with well-oriented lumpectomy specimen measuring 5 x 4 x 4.2 centimeters. External surface was congested. On cut grey white areas were identified, measuring 3.8 x 3.5 x 1.5 centimeters. The tumor was 5 centimeters, 1 centimeter, 0.2 centimeter, and 0.3 centimeters from the superior, medial, and deep resected posterior margins respectively. The tumor was enclosed to the lateral margin approximately 0.2 centimeters away from the inferior margin. The section examined showed infiltrative ductal carcinoma of the left breast lump. There was presence of lymphovascular invasion. The tumor was 0.1 centimeters from the lateral margin. All other margins, included the deep resected margins, were free of tumor. The modified BR score was 7, a grade 2. Receptor status of Ki67 labeling was less than 14%. A surrogate molecular classification of luminal A. So the patient is now ER positive, PR positive, and HER2 new negative.
Change हुआ कुछ?
PR positivity change.
तो कुछ फर्क नहीं पड़ेगा. Still luminal A?
Still luminal. The container labeled axillary lymph node dissection received fatty soft tissue pieces measuring 8 x 4 centimeters approximately. On sectioning, 10 lymph nodes were identified, of which only 1 was involved with the tumor. All the rest lymph nodes were negative for tumor. Another container labeled nipple areola measuring 0.4 x 0.2 x 0.1 centimeters. The section examined showed unremarkable nipple areola complex. A container of more sentinel lymph node received a single bisected lymph node, measuring 1.2 centimeters in diameter. Section examined showed 1 lymph node which showed tumor deposits. Another container labeled cavity shaving received a flap-like structure measuring 3 x 2 x 1 centimeter. The section examined showed fibrocystic changes only. The impression was created of an invasive ductal carcinoma, NOS of left breast, PT2N1MX. The note was taken. 2 containers labeled sentinel lymph nodes were also received, of which 1 was positive for tumor deposits.
Okay.
What was the surgery?
We did breast conservation surgery.
Breast conservation.
Now patient will require radiation 100%.
Clinically also it was T2N1.
Yes, sir. Pre-operatively also.
But it was a relatively small breast. Yes. Didn't you consider neoadjuvant?
Good question. We did not because we could achieve the results.
You're bugging, wonderful, that's true.
And actually we have seen that mostly the indications for neoadjuvant chemotherapy in smaller tumors, T1, T2 is when they're triple negative, where you can get PCRs, PAT-CRs to know that they're going to behave differently. In a luminal A.
But my this thing was only for surgical.
No, I agree with you. So could we have put this patient on neoadjuvant hormone therapy? That's the question.
That would have been
She's ERPR positive, so that is an option. But otherwise, we are not expecting her to respond very well to chemotherapy, and we could get the margin. And actually, to be honest with you, the pre-operative size we thought was smaller than what we found, and which is very common. Therefore, on the table, we should do our own ultrasound, and that's what we
Yeah,
have done.
you need to put clips also.
We put, we actually, neoadjuvant chemotherapy therefore was not considered. Now, the radiation part is naturally, she's conservation, so we'll do that. We put the clips there, everything. You should have shown the pictures of now, which is what would have helped. Now, chemotherapy.
She will undergo standard T200.
Anthracyclines followed by taxanes, followed by hormonal therapy.
ACT followed by hormonal therapy.
There's one interesting case which is in the ward. We had put the patient on LABC patient on ERPR positive, but we put on CAF regime. She responded to a degree. We didn't use taxanes. No? So I asked her in front the same question. She was ERPR positive, but we LABC, so we thought what is available with us. She's done well with that. So we don't taking her up for mastectomy tomorrow. So maybe we'll get a final histology and we'll look at it. Is that case also just for discussion today? So that was where we. So she will require chemotherapy. She will require radiation. Anything specific? I think you must appreciate when she will get all luminal A kind of a treatment. But you must appreciate when it has changed dramatically, the pathology reports. Ours are as good as Tata. We got that same, and they work very hard to get us. Already I kept chasing him. He's the person behind it all. And the best thing that has happened is, I must tell you, this patient would have gone for a second surgery, which would have been mastectomy only. If we didn't have the imprint cytology on the table for the margin, he was with me, so he'll agree. We went for a cavity shape is negative. Even that margin was negative, but there was a doubt raised, so we could do it in the same sitting. That really was a big help.
Sir, 0.2 centimeter तो almost positive margin मारी जाती है.
नहीं, 1 mm is I think is safe enough now.
No tumor on the income. We are not, nowadays the
1 millimeter is safe.
We are fine. So radiation and chemo both, and followed by hormone therapy. You can read the MDT decision.
MDT decision is to go for adjuvant chemotherapy followed by hormone therapy and radiotherapy, of course. So,
sequential ऐसे वैसे तो निकलो. Adjuvant chemotherapy followed by radiation followed by hormonal. We should never use static therapy along with sidal therapy. उसको पढ़ ठीक है ना? तो radiation
giving together.
नहीं मैं वो बता रहा हूँ कि logic क्या है.
They are the same. More than static versus sidal, the cycles in which it acts. Which cell cycle phase it acts?
So S phase in which the chemotherapy acts, and it is the G phase where the
G2
hormone therapy,
G2. And this is either cytostatic versus cytocidal. You don't club the two. Chemotherapy wants rapidly proliferating cells. As we discussed last time, running terrorists rather than hiding terrorists.
So it will be chemotherapy, adjuvant radiotherapy, and adjuvant.
अरे उसको देख करके ना वो बाहर वेट कर रहा है. पढ़ लो उसको. नहीं ये बैठ के पढ़ो. थोड़ा मुझसे डिस्कस करें.
Definitely.
Actually, we discussed with her, which point she raised. We discussed yesterday also with the lady. I discussed before surgery about the family. So she's got already family's done. She's not interested. If she was interested, what are the options we have? One is?
So gonadotropin suppression can be done so that the ovaries can be put to sleep for that duration, and then when she wants fertility again, then.
Or other options? Can we cryopreserve?
Cryopreserve the embryo or the eggs.
These are your answers in the exam, so that you can give it. You can cryopreserve and.
See, you can use all three things. You can use gonadotropin suppression therapy, Soladex, and all that. You can do oophorectomy, 100% sure shot removal of ovaries, no function remaining back. Or if it is not possible, then radiation oophorectomy also can be done.
Oophorectomy is done by chemical castration, that is considered equally effective. Otherwise, the options are laparoscopic, salpingo-oophorectomy. It's not oophorectomy, salpingo-oophorectomy.
Even our chemotherapy also will.
By chemotherapy, we will achieve menopause.
बहुत सारे patients amenorrhea achieve कर लेते हैं. They never.
What is the significance? Now they are all here. So what is the significance of achieving? What is the difference between those who get stealing this question, amenorrhea, versus those who don't get it on chemotherapy?
So response means those who got menopause can be an indirect evidence that they are responding, and
those who achieve menopause are better responders. outcome is better. That is the opinion. Next case.
If this patient didn't
It's
have
the
any
last
notes, it was a T2 and 0. She's a 36-year.
No notes.
38, huh?
30. So again, you are working in Scotland. Maybe some like
Hypothetical question.
And you're working in Scotland, which I raised the issue last
Yeah,
time. You
so-
are working in Scotland.
So again, the patient has come to you. She has done an MRI breast, which we all agreed that it is a very good
See,
model.
because I'll clarify to you all. Radiologist is here, I'll clarify to you all. There are centers where, as a routine, before breast conservation, you do MRI. I'll just complete it. Laszlo Tabar was a topmost leader whose course, there's the milk line of Tabar also. In the memo, they mandate it. And there are people who prefer it over even pathology. I mean, I'm just mentioning it. But there are many centers where they don't do it. The guidelines say it's not mandated. So, as of now, the guidelines say it's when equivocal diagnosis you can use it. So, problem solving tool. And I say problem causing tool. Why? It picks up too many artifacts and then you go places. Then you don't do breast conservation. So, it has reduced the increased the mastectomy rates. That's the problem. You were saying something.
So I was just saying that the patient is cream of the cream. So she wants the best of the treatment. T2 and 0. Now she says, I don't want chemotherapy. She's 36. She's particular about, like she's Lisa or somebody. She's particular about appearances, don't want hair loss, don't want anything. Would you avoid chemotherapy for the patient? So there's a molecular classification for which you do it, and there's an option of avoiding chemotherapy.
For short of Oncotype DX, which are the
Indian
panel?
Indian का वो क्या है?
What are the markers? I taught you the other day. This was discussed.
क्या नाम
What
क्या
are the
उसका?
markers? ERPR, HER2 new and
Chi 67.
Ki-67. And based on that, you can basically the whole idea is that we're observing the same thing that I was discussing. ERPR positive tumors, unless they're HER2 overexpressive, they don't do very well. That is trastuzumab, so I'm keeping that aside. ERPR positive tumors don't do very well with chemotherapy. And if it is a smallish tumor, you're falling in that zone of the Z11 kind of patients where we don't need to do even extraded dissection. They find you just find 1 to 2 nodes positive and you don't do extraded dissection because we are looking at good tumors. Chemotherapy can be avoided, but then they looked at which are this group, which is that group. So good tumors, elderly, ERPR positive, so they got down to Oncotype DX. Based on that panel, which is 1 lakh rupees, how much is it?
नहीं सर 3.5 लाख का है।
3.5 lakh.
इंडियन वाला है जो है ना मैमा प्रिंट। मैमा प्रिंट
Oncotype DX is 2,80,000.
2,80,000.
सस्ता हो गया।
ये सस्ता हो गया।
पहले बहुत ज़्यादा था।
So I think the 1 lakh से कम किया। No waiting list. Can you imagine that? So that's just to find out whether they need chemotherapy or not. So whenever you offer it to a patient, he says, don't forget it. They'll come back. But a lot of them will opt for it, as you said. So Oncotype DX is an option to not give chemotherapy to these patients.
Oncotype DX होता क्या है? जेनेटिक है, morphological है,
21.
proliferative है, क्या है?
It's a 21 gene panel assay basically to
To see what?
to see the genes which are mutated and
It gives a recurrence score, and based on that you can stratify. The higher the recurrence score is, the more chances it's going to death.
To look at the RFS, recurrence free survival. Chalo, next case.
Last one, so that nobody prescribes Oncotype. I brought out this thing, but again, I will reiterate my statement again. How many patients were included, the Indian patients or the Asian subsets that in that Oncotype when it was published? It was published in NAGM. It was presented in World.
Any Indian patients included in that?
11. So out of the many thousands, probably more than 3,000 patients, only 11 Indians were there.
Almost negligible. So it won't fit into our scenario easily.
75-year-old gentleman, sir. He is a resident of Saket, presented with chief complaint of difficulty in swallowing food, sir. He is having this complaint since 1 month, sir. There is no history of difficulty in opening mouth or protrusion of tongue. There is no history of excessive salivation. There is no history of earache or slurring of speech, and there is no offensive smell, and there is no ulceration over tongue, sir. Patient is a non-smoker since 25 years. He takes 25 BDs per day and he is an alcoholic. He takes around 30 ml every alternate day, sir. He takes mixed diet, normal sleep pattern and normal bowel and bladder habits, sir. He is a known hypertensive on oral medication, sir. And he has a history of pulmonary COX for which he took ATT 25 years back, sir. On general physical examination, his BMI is 18, sir. And Karnofsky's performance status is 90. He has pallor, sir. There are no signs of icterus, cyanosis, clubbing and generalized lymphadenopathy, sir. On examination of head and neck, sir, on inspection the surface of tongue appears normal, sir. Dental caries was seen, sir, and mouth opening is greater than 3 centimeters, sir. There is no difficulty in protrusion of tongue movements are normal, sir. On examination of neck, around 1.5 into 1.5 centimeter lymph nodes swelling is seen on level 2 of left side of neck, sir. Floor of mouth, GB sulcus and anterior 2/3 of tongue and soft palate and tonsillar fossa appears normal, sir, on inspection. This image shows around 1.5 cross 1.5 lymph node in level 2 area of left side of neck, sir. And this is the oral examination pictures, sir. Anterior surface of tongue is normal, sir. Dental caries.
Okay, it's alright. Yeah, they would like to see.
On palpation, anterior 2/3 of tongue is, there is no induration on anterior 2/3 of tongue, sir. And there is induration felt on left side of behind circumvallate papilla, sir. It is extending up to midline, sir. And the posterior margin, I couldn't elucidate it properly, sir. All the inspectory findings are confirmed, sir. There is no other induration over the anterior 2/3 of tongue, sir. And on palpation of neck, sir, there is 2 to 3 lymph nodes in level 2 area, sir, and of which the largest is 1.5 plus 1.5 centimeters, sir. Contralateral neck, no nodes were palpable, sir. Patient got biopsy taken in outside hospital.
Report, you can read the report.
It shows moderately differentiated squamous cell carcinoma, sir, left base of tongue, sir. MRI of face and neck was done on 26th of February, sir, which shows hyperintense signal on T2 weighted and stir images on left side base of tongue, sir, bulging into vallicula and its partial effacement, and also involving the median glossoepiglottic fold, sir, and left side of epiglottis, sir. There is an enlarged lymph node of size 1.4 into 1.1 centimeters in level 2 of left side of neck, sir. And few other sub-centimeter lymph nodes are seen in bilateral neck, sir, involving level 1, 2 and 5, sir. CECT of face and neck was also done, sir, which the findings of CECT is almost similar to MRI of neck, sir, and involving the same regarding the CECT images, report is similar to MRI report, sir. This is a T2 weighted image of MRI, sir, showing this is the lesion, sir. It is in the posterior aspect of tongue, sir. This is the lesion, sir. And he got a PET scan done, sir, which showed there is a image involving the left base of lung, sir. And no other.
He's been a pulmonary COX in the past. So the SUV looks the same for the primary and this.
It looks morphologically to be a sequel to pulmonary COX only.
Is it? Okay.
But since it's PET positive, then.
That's why this is the problem with PET. We get still nodes, especially in the lung.
This is the lung lesion.
It's a cavitary lesion,
Okay.
which is query infected, query mitotic.
You have to get a biopsy.
Without a biopsy, we will never be able to confirm.
Biopsy is being planned.
That is why we instead of PET, we could have just done a CT chest. Would have been.
He brought it.
He brought it from Max.
Yeah, I know.
So we would be going for CT guided biopsy, which is dated. He was waiting for you that day, yesterday. Now,
But the uptake looks much higher than.
it looks
than
higher,
old tuberculosis.
significant, of course. Okay. That's what I was asking. They're looking like primary as well as the lung lesion match.
It's almost similar.
Almost similar. So rest of the findings would be more or less the same.
Can we just go back to this primary lesion? So can we Can you just tell us more about that lesion?
Okay.
How much is the neurovascular
So these
involvement?
are the coronal images. If you can see that you have two T2 images, but there is one T1 image. So, like I said, you can see the ventricle here. So it's hyper, it's fluid. Fluid is hyper on T2. So it is a T2 weighted image. And you are right, this is the posterior aspect of the lesion. I say so because I see the sphenoid sinus. So on here we have an irregular enhancing lesion. It is, I haven't seen this case before, but it appears to involve the left-sided geniohyoid muscle.
Yeah.
And inferiorly it is abutting the mylohyoid obviously. T1 is not very helpful in this case. Additionally, the patient also has some lesion inside the maxillary sinus. It looks like a polyp. Looks like a polyp. And
The neurovascular?
so it is T2 weighted hyperintense. Unfortunately, she has not included sections for the neurovascular bundle. But since you mentioned,
I couldn't see, that's why I was.
Since you mentioned median glossoepiglottic fold, I'd like to say that this is the median glossoepiglottic fold. These are the two lateral glossoepiglottic folds. So you can see that this is the lesion that is extending beyond posterior margin that is involved in this.
And there is ankylogloss. So in any case, it's not a resectable disease for us. We are looking at something from both the gentlemen, three of them. So what should it be? What should be the same approach, same induction?
Get the biopsy. Get the biopsy.
CCRT and biopsy we have.
अगर biopsy negative है तो सर फिर तो CCRT.
Suppose biopsy is inconclusive, which will happen? I'm telling you.
It can give the benefit of doubt and give.
नहीं फिर नहीं.
सर डाउटफुल है तो कैसे करोगे? अगर इनकंक्लूसिव है तो आप कैसे उसको लेबल करेंगे?
नहीं, मैं agree with you, आपके बहुत सारे पेशेंट आते हैं, मैं बता रहा हूँ, उनकी बायोप्सी, I mean it's very hard to reach it, and unless you do VATS or something better than that, because the biopsy will be difficult to reach.
It's a very large thing.
Suppose we get it, and it is inconclusive.
Instead of 4, we will take 6.
So CT guided lung biopsy depends upon various patient factors also. Like the patient has to lie still and needs to have a regular breathing. Secondly, this lesion is surrounded by lung on all sides. So there is a very high chance of pneumothorax.
Yeah, you're getting through. That's what I was trying to say. It's inaccessible to reach it, and then to get an inconclusive report is like, putting a wild dog behind you.
So would you prefer the CT guided biopsy or you would prefer the bronchoscopic? Because I can see those.
Sir,
we have to do the biopsy.
Since lesion is very peripheral, so CT guided biopsy, I will prefer that.
It is obviously not through the bronchus. It's quite far. Then you will be like, wow, Afghanistan, Pakistan, India.
Pneumothorax will not.
Also, sir, they cannot reach the terminal bronchioles in bronchoscopy.
No, but actually that's a protocol. We don't have a choice. We have to do the biopsy. If it comes out to be inconclusive, we'll assume that it is positive. I agree with you in that sense. Maybe he's saying repeated, but repeating is a challenge. And it is highly suspicious in PET. So there is no way you can take, it can't be labeled as a tubercular lesion as far as the PET scan is concerned. We need to be using a little bit of common sense there. Our intent may become a little less curative. That's what I'm trying to say.
And he has had a tuberculosis. He has had ADT 25 years ago. We don't know whether any AFP is there or not. If you give just chemotherapy without any biopsy,
she has not put it the X-ray chest. The X-ray chest shows all the heat lesions.
It will blow up like anything.
And then you had it.
And also the lesion is in the bases. So TB usually affects the
apex. So unusual, unlikely. This is tubercular because if you see the X-ray chest, which I saw yesterday, the lesion, most of the primary complexes are in the upper part. They are all healed up. This is a lesion lower down. This is a highly suspicious.
I don't even agree with the Karnofsky. He is 78 years old with about 70 Karnofsky's. He's not too fit. So I don't know.
He was
He said 90 का मैं इसलिए बोला.
No, I'm coming to it. It will be around 80 because I saw him yesterday. He won't be. He's not so bad considering his illness. He came walking, he sat, and he braved the corona virus also. So that makes it performance status. 10 marks तो उसी के हैं.
नहीं अंडे वंडे खिला दो ठीक हो जाते हैं सर खा तो रहे
He's actually not too bad, but not so. No, he's not 90. He's not 90. He'll be about 80. 80 to chalega, you can manage. Now, why are they so fussy about it? What happens if it is below 60?
Patient is bedridden and is not fit for any therapy.
It's not. Then treatment should become worse than the disease. No?
Supportive
Treatment should become worse than disease.
Don't say no therapy. Where supportive care is a
supportive care.
No definitive therapy.
Definitive therapy.
Because they are toxic.
There was a time when there was no chemotherapy. Surgery was in its initial stages. All the patients of oncology, they used to die off in best supportive care centers. That is all they used to do, nursing.
They used to do tuberculosis.
Symptomatic things.
Fine. So for this, the MDT decision is same induction chemo PCRD.
First biopsy.
Biopsy followed.
Biopsy
Then followed by.
What was the T of the lesion? The T size.
Sir, it's T3, sir. It's
Could be certain.
Sir, no, sir.
So how would
Based
you
on
say
the
that
CT findings, sir, it is involving the left side of epiglottis, sir. So it
Will it be
involves
T3 by any chance?
if it involves the
It
lingual
can't be,
side
no? So it's T4 anyway, any day. Anytime it involves a contiguous organ, what happens to the oral cavity stays?
T4.
So don't say T3. Size is over now.
Yes.
Now it's, the moment it goes out, it's different.
If it involves the lingual side of epiglottis, it is written it's T3, sir.
How would you know that on, the TNM stage based on clinical examination? Achha, okay, it is involved the floor. Has it involved the floor of the
No,
bone? There is ankyloglosia.
It's the floor of the
It's a floor of the bone. It's clinically also involved. There is ankyloglosia. What is the reason for ankyloglosia, Ravita? It is involved in the floor. And that itself becomes T4, no?
The lesion is
Well,
lower down.
Thank you very much, Dr. Kadaria, Dr. Vikas, Vikas, Amit, and all of you. Can you read out the MDT? Last you didn't read out, it was late to read. I didn't hear.
The MDT decision is to get a CT guided biopsy of the lung lesion followed by CCRT.
Yes, we didn't hear. When did you say that? Followed by any place for surgery?
Sir, maybe salvage surgery after that.
Okay. Decision for one. How about the neck? Is neck dissection superior to radiation when it comes to neck salvage?
Yes, sir.
Ah.
That's,
So many times surgical
Maybe
approach to
less
neck
morbid.
is less morbid. What would be the difference in neck dissection post RT? Difference between what
Sir.
we do? Can you do modified radical leg dissection? The answer is
sir.
no.
No, sir.
You do
Radical-
radical leg dissection because the planes are all distorted. Now you'll have no way to do modified. So post RT,
और
wrong.
क्या होता है problem?
Technically difficult. What happens to the flaps?
So necros.
The flap failure rates are high. Seroma rates are high. All morbidity.
So the blood supply.
सर ने तो बोल दिया सर ये तो पीछे बहुत सालों की नॉलेज है आपने पूछा नहीं कि दी वाई फेलियर रेट्स आर हाई बताओ
So post RT there will be the.
क्या होगा
So because there is no plastic reaction in the destruction. So the flap will be less vascular.
फैंसी ट्रांसफर यूज करिए
Now I'll simplify it for all of you so that we save time. One, flap. Therefore the incision is different. We don't use modified Schwingers. Modified Schwingers is when we use the parallel to this and then a lazy S. We use McPhee incision, which is also called step ladder. So that flap you can lift up and work. Flap failure rates are low. Number one. Number two, the desmoplastic reaction will make it difficult to know the disease and no disease. So you do radical leg dissection. You will, with impunity, remove sternomastoid, spinal accessory nerve, and angiography. You won't bother about anything. These two will remove. Thirdly, the flap rates are higher and blowouts. So carotid has to be covered with some kind of a flap. So you can use a platysmal flap. Watch the video on YouTube, my old video, very old video, and Vinay was my teacher. R&D with platysmal flap to cover it. Because with radiation, there's a chance that it's going to blow out. And trisection should never rest on the carotids. The technical challenges. Higher seroma rates, floating flaps, failure of the flaps, too many